I want to talk tonight about the core fiscal challenge that we face, and I have two propositions for you. First, we have misdiagnosed the nation's long-term fiscal problem and described it mostly in terms of aging and demographics, when in fact it's mostly in terms of the rate at which healthcare costs grow. And secondly, that embedded in that central fiscal challenge and other challenges related to that we face is a very substantial opportunity to improve the efficiency of the health system, and in particular to reduce costs without harming health outcomes. So let me try to back up both of those propositions. First, let's look at the nation's fiscal future. The nation is not on a good fiscal course, and any way you cut it, we face very severe pressures over the long term. I think it's pretty clear even from that graph that most of the growth, and by the way, these are based on our projections, but there are other projections that tell a broadly similar story. Most of the growth is associated with Medicare and Medicaid, and yet most of the attention that has been paid historically to the nation's long-term fiscal problems has to do with Social Security. And I was describing before, I have a 6- and an 8-year-old. Even my 6- and 8-year-old see that the light blue area of that curve is the part that's growing fast, and the dark blue area of the curve does go up, but it's not as big a problem over the long term, which is not to say that it's not a problem. It should also be perhaps immediately clear that the same demographic forces that affect Social Security also affect Medicare and Medicaid, and yet you see this very different growth pattern in the future, which should give an early hint that demographics alone are not the key driver, even though they are part of the long-term fiscal problem. So this just says what I've already said. If you look historically, the rate at which the cost per beneficiary has increased compared to the way these things are typically measured is to compare how rapidly in healthcare the cost of each beneficiary is rising relative to income. And over the past 30 years, that growth differential has amounted to about 2 to 2.5% per year. So each year, the cost per beneficiary in Medicare or Medicaid or in the rest of the health system has been going up about 2 to 2.5 percentage points faster than income. One thing to note about that, by the way, is that that growth, that it's called excess cost growth. It doesn't mean that the cost is necessarily excessive. It just means in excess of income, is roughly similar in Medicare and Medicaid and in the rest of the health system. And that's not too surprising because doctors are treating Medicare and non-Medicare patients, hospitals are treating both kinds of patients, and so the practices that you see in one part of the health system tend to spill over into other parts of the health system, and you get cost growth over long periods of time that is similar in the public programs and in the private part of the health system, as you can see from this curve, or from this table. The projections that I showed you before extrapolate out some continued rate of excess cost growth, although we do assume that it slows a bit in the future, even in the absence of policy changes. And that, rather than demographics, is the key driver of the increase in Medicare and Medicaid costs. And in particular, we can decompose the total increase in Medicare and Medicaid into different components. We project that Medicare and Medicaid costs will rise from about 4.5% of the economy today, I should say the federal share of Medicare and Medicaid costs, will rise from about 4.5% of the economy today, 4.5% of GDP, to almost 20% by the end of our 75-year projection window. And let me pause, by the way, on that and just say, everyone always says, 75 years, how can you know that? Obviously, there's a lot of uncertainty about the future. Furthermore, these projections actually won't happen because they assume no change in federal policy. And one thing that is sure to happen is that federal policy will change in some way over the next 75 years. They're instead supposed to reflect a best guess, if you will, about the course that we are on if we don't change policy, rather than being a prediction of what will actually occur in the future, given that the world is uncertain and that policy will change. But they are our best guess, so let's take them for what they are. 4.5% of GDP to 20% of GDP. We can break that down into a couple different components. I think one way of thinking about it is, let's say the cost per beneficiary is fixed. So an 85-year-old, on an age-adjusted basis, an 85-year-old will cost some amount, let's make up a number, $10,000 a year. A 25-year-old will cost $2,000 a year. and then let's age the population the way that we project it to occur. So we allow the baby boomers to retire and the population to grow older. The pure effect of that aging is the dark blue part of this curve. So that's keeping cost per beneficiary at each age fixed in real terms, and then it lets the population age the way we project. And I think you can see there's some increase, but it's not where most of the action is. Most of the action instead is rising cost per beneficiary. So it's not that we're going to have more beneficiaries, or I should say, it's only a little that we're going to have more beneficiaries. It's much more that each beneficiary will cost so much more in the future. Now there's an interaction effect, which is that light blue area. If the cost per beneficiary goes from $5,000 to $10,000, the fact that in the future we're going to have more 85-year-olds or more beneficiaries magnifies the impact of those higher costs for each beneficiary. That's what this light blue area is. And whether you treat that as aging or as cost growth per beneficiary is up to you. I guess the point is, even if you attribute that to the aging part as opposed to the increase in cost per beneficiary part, you can still see that the vast bulk of the projected increase is not demographically related. And I would just pause and say, I spent a lot of time in the sort of think tank world and the DC policy world. The amount of writing, and I've been guilty of this too, the amount of writing and policy analysis that has been done on this piece is basically inversely proportional to its relative importance. So there have been way more books and papers and studies written about aging and demographics than about that piece, and yet, in reality, that piece is a much more important part of our fiscal future. And not only that, and we can come back to this, but I think the political economy, the way that our fiscal problems are framed and presented to the public has much more to do about this. So even though it's not the more important factor. So it's often framed as, or presented to the public as, one generation needs to sacrifice for another generation in order to solve this problem. Whereas actually we need to figure out how to bend the curve in terms of how much each beneficiary is costing to get at the key to our fiscal future. And again, I also want to say, by the way, some people have said, oh, well, what you're saying is we don't need to address Social Security or aging doesn't matter. That's not at all the case. To say problem A is bigger than problem B is not to say that problem B doesn't exist. And it still means that there are higher costs associated with the aging population, both in these programs and in Social Security. What I'm trying to make clear is that we've been misallocating our resources by putting so much emphasis on this as opposed to a more important variable. So we can also combine those spending paths on Medicare, Medicaid, Social Security, and other programs with the revenue side of the budget. And depending on what you assume about the revenue side of the budget, you have a fiscal path that explodes either basically immediately or explodes after a little bit of time. And I'm not going to explain the differences between these two unless you're interested in it. But basically, we're on an unsustainable course where debt explodes either very quickly or after some lag, depending on what happens on the tax side of the budget. I should also note, this also will not happen. There's no way that we're going to hit 400% of GDP in federal debt, because if we ever did, we wouldn't be able to sell anymore. And well before that point came, we would not be able to sell on financial markets an additional dollar of government debt. So again, this is not a prediction of the future. This is instead a scenario in which we present the implications of current policy, recognizing that that policy has to change because, will change because it has to change. This is not a feasible or realistic outcome. We can combine the spending path and the revenue path and calculate what many of you have probably learned about present value calculations that sort of collapse, taking into account the time value of money, a spending path and a revenue path, and say, how much of an imbalance do we face over, say, the next 75 years between spending and revenue? I want to focus on this bottom number, the 6.9% of GDP. If we take the present value of that spending for Medicare, Medicaid, everything else that I showed you in the first graph, and then I take the tax code as it is currently configured, so the marginal tax rates that exist. I don't let the alternative minimum tax, which is another part of the tax code, take over the tax code over time. We can talk more about that. And we project the tax code forward, basically in its current form. You get a gap between revenue and spending of 7% of GDP. What that says is you have to reduce spending by 7% of GDP or increase taxes by 7% of GDP today and hold it there over the next 75 years to avoid those debt explosions that I showed you in the previous chart. That may immediately strike you as being entirely unrealistic for any of you who know that spending and revenue are about 20% of GDP today. So what I'm saying is, in order to avoid those debt explosions, you either have to cut spending by a third or raise taxes by a third today and hold it there for the next 75 years. The fact that that doesn't strike you as being, from a political economy perspective, particularly realistic, just illustrates the deep divide that we have between the fiscal course that we're on and the actions that we've been willing to take thus far to avoid the outcomes that ultimately can't happen. I can decompose this fiscal gap similarly into a part that's due to aging and a part that's not due to aging. And just like with the Medicare and Medicaid numbers, you see the part that's due to aging by itself is not that big. Out of the 6.9%, most of it is not due to aging. And again, I would just say, if you look at the press coverage of our long-term fiscal problem, it is almost always framed as we have this coming, wave of baby boomers who are going to cause a catastrophe for the federal deficit, and that's this part. Whereas we need to be spending a lot more time and attention on the lighter part of the bar. So that all sounds pretty depressing. We've misdiagnosed the nation's long-term fiscal problem. Most of the national press is getting the nature of that problem completely wrong, and we face this 7% of GDP gap between spending and revenue. It's almost like we should just go home and give up because it's hopeless. But I don't reach that conclusion. And the reason I don't reach that conclusion is embedded in that key problem, or the key variable that will affect our fiscal future, is that rate at which healthcare costs grow. Seems to be an opportunity to improve efficiency, that is, to reduce costs without harming health outcomes. And that opportunity seems to be very big. In particular, I have a panel of health advisors that includes lots of great and notable health analysts from across the country, and I've asked them this question: what share of health, leave apart the political economy difficulties of actually doing it, what share of healthcare costs do you believe you could reduce without harming health outcomes? And 2 out of the 15 or 20 of them said, "That what a stupid question, I'm not even going to answer it." But the rest of them answered it, and the answers came back between 5 and 50%, with the modal answer, so the most common answer, being 30. 30% of 16% of GDP, which is what we currently spend on healthcare, is 5% of GDP. I have Alan Kruger and others in the audience. There are not any other academic studies that I know of that get inefficiencies that are anywhere close to 5% of GDP. Or another way of putting it is, I don't think I can get a credible academic to identify a specific area, whether it's high marginal tax rates or the impediments to international trade or so on and so forth, that get you inefficiencies that are more than 0.5 or maybe 1% of GDP. Or another way of putting it, this is a triangle and not a rectangle. I mean, this is not a triangle, this is a rectangle. This is much bigger than anything else that credible academics would say exists. And so I want to explore a little bit why that may be occurring and what we could possibly do to capture that opportunity, because 5% of GDP for no adverse consequences to health outcomes is so much larger than any other opportunity that we seem to face that it is striking to me we won't spend a lot more time exploring how to get there. All right, so that's a pretty bold statement. Let me try to back it up a little bit. What is the evidence? And there's a variety of evidence, but what's the evidence favoring this kind of inefficiency? I think the most compelling evidence is the work that has been done up at Dartmouth on the regional variation in healthcare costs across parts of the United States. So let's first talk about that. This map shows you different parts of the United States, the darker blue areas, and I should immediately say we alternate. Sometimes this is presented in red and sometimes it's presented in blue. Right now it's blue. The darker blue areas of the country have higher spending than the lighter areas of the country, and the differences are very substantial. Even within states and within different regions, you can see very substantial variations in healthcare costs across the United States. Now, the team up at Dartmouth has tried to explain this variation. They said, initially said, well, it may be that some of the people in parts of the country have higher income and they demand more health care. Or it may be that they have more generous health insurance and they demand more health insurance. By the way, this is Medicare, so that doesn't really hold. Or it may be that the people down here are sicker than the people up here, so of course the costs are higher. Or maybe the cost of building a hospital is a lot higher in one part of the country than another, so that affects costs, or the cost of living, what have you. You throw all that stuff together, and the best that this team that's tried to spend basically its entire professional life explaining this variation can come up with is to narrow the variation by maybe a third, which is to say there's a huge amount of unexplained variation that exists after you try to control for everything that you can throw in. I was telling Senator Frist earlier, I was giving a speech a couple of weeks ago, and someone was very excited and said, I have the answer. That variation is caused by cloud cover on particular days in the United States. So people are always coming up with novel explanations, and I would just say the team at Dartmouth has spent a lot of time trying to tease out the factors that would influence health spending and how much you can explain, and the answer is they can't do very well. The kicker, of course, is that the higher spending regions on average don't generate better health outcomes than the lower spending regions. And in fact, if you look at the simple correlation, if anything, it goes the wrong way. If the higher spending regions were generating better health outcomes than the lower spending regions, given the admittedly imperfect indications of quality that we have, this scatter plot should be upward sloping. And I don't know how many of you are taking statistics, but I bet you can see it's not really upward sloping. And in fact, if you do the simple correlation, it does go the wrong way. So that opens up this interesting question. What if we were able to move the darker blue areas of the country towards the lighter areas of the country? What would happen? The folks at Dartmouth say what would happen, and this is one of the bases for that 30% estimate, is that we could reduce costs by 30% across the United States without harming health outcomes on average. Pretty big opportunity. I would also note, by the way, before I go on from this slide, we always do these comparisons to other countries. So the U.S. spends 16% of GDP, and other countries spend 10, and and we don't seem to have better health outcomes. Those are always contaminated and made difficult by all of the cross-country differences that exist. It strikes me that there are huge variations within the same payment system, Medicare, that are worth exploring in a lot more detail. And in particular, those lighter areas of the country are delivering health care at the same cost relative to income and at the same quality or outcomes as other countries. So rather than suffering from all of the cross-country comparisons that we do, why not spend a lot of time looking within the United States at what's causing the variation and see what we can learn from that within a single payment system. So let's do that. And I think this also starts to point the way towards possible approaches that might help to capture that, let's call it the 30% opportunity. So why is this happening? I'm going to put forward a sub-proposition to my first proposition. I think the reason this is happening is too little of the health care that's delivered in the United States is actually backed by any evidence that it works better than something else. We have a payment system that facilitates more interventionist approaches, and in some parts of the country that there are social norms among medical professionals to do the more interventionist stuff. The more interventionist stuff is paid for by the federal government and other insurers. And because it's not backed by scientific evidence that it works better than anything else, it drives up costs without improving outcomes on average. So let me try to back that up below. First thing is you see the variation. So if you're on this vertical line, that map would be one color. And if you're away from the vertical line, then the color starts to open up. So you see the variation more significantly in areas where it's not clear what one should do. So as now Dr. instead of Senator Frist will tell you, if you have someone who's suffering a heart attack, admitted to a hospital, giving them aspirin is a best practice guideline. There's not a lot of variation in that. It happens. It's clear what should occur. There's a lot more variation in things where it's not really clear what should occur. So evaluation and management visits. You go in for surgery. You got your surgery done. Should you go back and see the doctor 3 times a month or 5 times a month or 4 times a month or twice a month? No one can really tell you. There are very few studies that evaluate the benefit of that 4th visit or the 5th visit or whatever it is. We don't know. In some areas of the country, you go back much more frequently because that's what's done there. In other parts of the country, you don't go back that much more frequently because it's not done there, and we don't know what we're getting in exchange for the extra visits. Imaging, diagnostic tests, so we were talking earlier, MRIs. MRI was clearly a very beneficial innovation. It allowed lots of diagnoses that would have been difficult to do before. It then gets applied in all sorts of settings where it's not at all clear what you're getting for it. And I actually had a personal experience with this. We were talking before. I am a marathon runner. I hurt my knee in the Marine Corps marathon a couple years ago. Go to the doctor, takes an x-ray. He says, you have ITB syndrome, and he sort of bangs my knee around a little. He said, now go get an MRI. And I wasn't going to pay for it, but I'm kind of time constrained. And so the thought of going to some other outpatient MRI thing and scheduling it, and I said, oh, do I really need to go? And the doctor said, well, it's probably a good idea. And I said, what do you mean by a good idea? The doctor said, well, it may matter. And I said, well, give me some sense of, what is the likelihood that it will change your diagnosis? You already said it's ITB, da-da-da. He said, it's low. And I said, what's low? And he said, really? And I said, yes. He said, probably under 1% that it would affect the diagnosis. And I said, I'm not going. But if I hadn't started asking those questions, I would have just gone. And that's a setting in which we don't actually, he probably was also making up his 1% estimate. He probably didn't even know. But there is no study that says I have to admit now, middle-aged marathon running male, ITB syndrome, is an MRI beneficial or not? What share of the cases will that actually affect the diagnosis? They don't know. And I was mentioning before, even most of the testing that we do is testing in pharmaceuticals, which, by the way, is only 10% of total healthcare spending, despite all the hoopla that you hear about that. It's not where most of the money is. But the testing that we do in pharmaceuticals, which is more intensive than in other parts of the healthcare system, even there, so in the best case scenario, the testing is a drug versus a placebo. And we don't really care whether a drug works better than a sugar pill. We care whether a drug works better than some other drug, works better than surgery, or what have you. There's very little of this kind of head-to-head comparison that's done in the United States. And the variation is more substantial where we don't know. And therefore, in some areas of the country, we just kind of do it this way. In other areas of the country, we don't. And we have a payment system that facilitates that. Now, some people go back to this map and they say, oh, that's all very interesting, but you really don't know the medical system. Look at those dark areas of the country. Those dark areas of the country have the nation's leading academic medical centers, and our leading academic medical centers deliver the best medical care in the world. And that part is true. If you're seriously ill, going to one of our leading academic medical centers is probably a good move. So let's look at our nation's leading medical centers, and I try to rotate these so that I'm not picking on any particular ones, but you see this across a wide array of medical centers. So for this purpose, we'll talk about UCLA Medical, Mass General, and Mayo Clinic. I think clearly 3 leading institutions. These are for Medicare beneficiaries in the last 6 months of life, so these people all tend to be quite sick. If you look at the admittedly imperfect quality indicators that we have, there's no big difference. If anything, the Mayo Clinic ranks somewhat higher. Now look at the cost per beneficiary. UCLA Medical, $50,000 a year for the last 6 months of life. Mass General, $40,000. The Mayo Clinic, $26,000. It leads, well, now Elliot Fisher, but there's been a string of these people who have been doing this kind of research to say, how can the best medical care in the world cost twice as much as the best medical care in the world? We are paying for, you, the American taxpayer, paying for this difference between $50,000 and $26,000, and we do not know what we're getting in exchange for it. There's some sort of intermediate indicators. You go to a specialist a lot more at UCLA. You spend more days in the hospital at UCLA. You visit a physician more frequently at UCLA, but you don't have any higher quality indicator. And also, we've constrained this so that, to put it bluntly, everyone's dead at the end of 6 months anyway. So in terms of an outcome, there clearly isn't any difference there either. So it is, at one time, both glib but also a deep question, why is this top medical care costing twice as much at one place as another? And again, I come back to, we are doing a lot more of this sort of discretionary stuff where we don't actually know that it helps at the more intense places than at the less intense places. And then we have a medical payment system, especially through Medicare, that pays for more care rather than better care. So we facilitate and we accommodate the more interventionist approaches even when it's not backed by any evidence. A couple other things on this variation, because we just put out a report on it, so other things that I found interesting. that variation, that map that I showed you in variation in Medicare cost per beneficiary, the variation in Medicare costs have actually declined somewhat over time. And if you look back 10 or 15 years ago, so let's say 10 years ago, well, I guess 15 years ago, the variation in Medicare was above that in the rest of the health system, and so it was above total healthcare spending per capita variation. But the variation in Medicare has been coming down, whereas in the rest of the health system and in total it's been flat, and so if anything now those have flipped. In any case, there's a lot of variation in the rest of the health system too. That decline in Medicare variation seems to be coming mostly from a decline in the variation in hospital costs, which are basically Part A of the hospital insurance part of Medicare, as opposed to a lot of the other components. And that in turn may be due to changes in the payment system that we made, especially in the 1980s, although I know it doesn't correlate perfectly because the decline in the hospital variation was occurring before we switched the payment methodology in Medicare in the early 1980s. But in any case, there's been a very substantial decline, especially in hospital cost variation in Medicare. Probably won't surprise most people that the variation in the United States is higher than in, say, the United Kingdom or in Canada. But, and I forgot whether I have a slide on this. No, I don't. But the variation in Medicare is about the same as it is in the Veterans Administration health system within the United States, which might surprise you. Because the system of allocating costs across the VA system is somewhat more similar to some of the foreign countries that we often are compared to than it is in Medicare, and yet the variation in the VA system is just as high as in Medicare. We'll come back to all that in a moment. So the first thing about this opportunity that I think is important is there's a lot of variation. By the way, that variation occurs, as I think you should have gotten from the total healthcare spending variation, not only in Medicare, but in Medicaid and in the rest of the health system, in the private part of the health system. Second fact about healthcare that you need to keep in mind is spending is very concentrated. Catastrophic cases in particular account for a very large share of total costs. So the top 5% of Medicare beneficiaries account for more than 40% of costs. The top 25% of Medicare beneficiaries account for 85% of costs. That's one reason, by the way, when and I'll get to this in a moment, but if we start talking about changes in financial incentives, changes in financial incentives for consumers can help, but we're almost always going to provide insurance against catastrophic cases. You see that in a health savings account approach, or you see that in other approaches to more consumer-directed health plans or a healthcare system. And that means that the increased cost sharing that you get, or the improved financial incentives for consumers, if you want to put it that way, almost necessarily is applying against a relatively small base of total spending, because the catastrophic cases are still fully insured. Or another way of putting it is, most of the consumer-directed kind of stuff applies to these beneficiaries, the non-catastrophic ones, but they account for a really small share of total cost. So you don't get as much traction as you would otherwise think. All right, so what do we do about all this? And obviously there are big healthcare debates going on, and I'm going to sort of stay away from those, and I'm going to just try to focus on costs rather than coverage, which is seems to be generating more, at least policy attention right now. Strikes me that there are a couple interlinked steps that we can do given the case that I've tried to lay out. One is, to the extent that a lot of this is being driven by simply not knowing what works, we need to figure out what works. And regardless of whether you favor a single payer or a consumer-directed health system or something in between, you should favor having more information on what works and what doesn't, whether that MRI makes sense or whether the fifth visit makes sense. By the way, I have an HSA. I don't know whether going to visit the doctor if I had surgery, whether going to visit the doctor the extra time would be worth it or not, because you can't get the information. And so in that approach, or in a single payer approach, or in anything in between, more of that information is necessary. And this comes under the heading of comparative effectiveness research, where you're comparing the effectiveness of different medical interventions. One of the ramifications of that is, it is highly unlikely to me that we're going to be able to build out the information base, think, the fifth visit versus the third visit, solely using randomized control trials. because you're going to have to study such a wide array of things relative to what's already being done, and study subpopulations in a way that it will be probably too expensive and impractical to conduct randomized trials and everything, which is to say that the medical profession will likely have to struggle with the imperfections of panel data econometrics, the same way that economists have for a long time, at about the same time that economists, having grown frustrated with those imperfections, are yearning for and conducting more randomized trials. So maybe the two will kind of meet a little bit. And to have the input or the data for those panel data econometrics or statistics, a health information technology backbone that has electronic health records as part of it would be a major source of information, and assuming that there were appropriate privacy protections, could open up a lot more analysis than is currently possible. Most of the data that we currently have is limited or imperfect for various reasons. So some people like to use insurance claims to study this kind of thing. The problem with insurance claims is it doesn't have any outcome measure associated with it except when basically you die. So you know what was done to you, but you don't know what your blood pressure was or your biomarkers or any other things, and so you don't know what benefit you get. There are some individual registries where people try to collect that information, but what you need is both what's done to you and what happens, and sort of what the outcome is, in one electronic format to conduct the kinds of studies that would be beneficial. Second thing we need is, right now we have financial incentives for more care rather than better care, so doctors and others get paid based on basically how many procedures they do, and or how many MRIs are undertaken, and that does not create the right incentives for efficiency. It creates the incentive to have more healthcare delivered, and that's what we wind up with, but more healthcare doesn't necessarily mean better healthcare. I'd also note that well, first, to know what better care is, we need more information, so that links back to the first bucket. But secondly, it seems to me impractical or unlikely that we're going to have hard coverage decisions where we say that is simply not covered because it doesn't work, be sustained over time in a political economy sense. It seems more likely to work or be sustainable if we say, you know, the evidence says that doesn't seem to work as well as this other thing. If you want to do it, that's great, but the provider's not going to get paid as much, and you're going to have to pay more to undertake that versus this that's been shown to be more effective, as opposed to we're not going to pay anything or we're not going to cover the less effective thing. That requires a more nuanced and complicated structure. There are also questions about delivery systems, integrated healthcare systems versus non-integrated healthcare systems, physician group practices, and we can talk about these. But I wanted to pause on this. I think relative to frankly, what I was taught and that what's still the dominant paradigm in economics, although it's changing quickly, and that informs a lot of policymaking, we have paid far too little attention to ease, simplicity, salience, and actual decision-making relative to financial incentives for consumers. And most of policymaking is still based on a theory of human behavior in which, for consumers as opposed to providers, financial incentives are the dominant influence on behavior. And I think we have learned that in retirement saving, where opt-out 401k plans have a bigger impact on participation rates than any conceivable match you can come up with, on toll roads, where an easy pass has a much different effect than paying out of your pocket. Even on the political economy of the payroll tax versus the income tax, 3/4 of American households pay more in payroll tax than income tax. You hear a lot more about the payroll tax, about the income tax, because it's more salient to people. And you can go down the list after list after list where the pure financial incentive may matter, but it doesn't matter as much as how things are presented, what's easy, what's simple, what the default is. And I think we need to be experimenting a lot more with that in policymaking, because it seems to just empirically be a lot more important. On health behavior, we're sort of nowhere near where we need to be on making it easy and simple to lead healthy lives. And most of the defaults are flipped in the wrong way. So, and that we can encourage better eating and health habits and exercise through various interventions, which may not be government interventions, they may be business or other structures, but we sort of haven't filled that out as much as we could. And I'd also just note, I'm going to skip the other things because I want to leave plenty of time for questions. I'd also just note that social norms among doctors has gotten far too little attention. Why is it that the doctor is ordering this test, or why is it that the doctor is paying attention to the doctor down the hallway? How do doctors and medical professionals themselves make decisions, which will be influenced by financial incentives, but it's also influenced by other things, as you can see by the huge variation that we have across parts of the United States, because the financial incentives actually are quite similar in Minneapolis as they are in Miami, and yet the outcomes in terms of intensity of healthcare delivery vary a lot. I'm going to just wrap up by saying we're doing a lot more at CBO about healthcare because for the reasons that I hope are obvious at this point. I wanted to just end on one topic that I think has not gotten enough attention. And that is, we've heard a lot about inequality, income inequality, and growing disparities in incomes. We've heard much less about growing disparities in life expectancy, and yet that is happening to a surprisingly large degree. So most people know life expectancy is going up. A lot of people know that folks like in this room, better educated, higher income people tend to live longer than less educated, lower income people. I think very few people know that that gap in life expectancy is increasing markedly. So for example, if you look at from 1980 to 2000, age 65 life expectancy, here's the increase in average life expectancy that you've heard so much about. Here's the increase in the gap between higher socioeconomic status, that's better educated, higher income people, and lower educated, less income people. The increase in the gap is almost as large as the increase in the average. There's another study actually that was just out in Health Affairs by David Cutler at Harvard and a few others that suggested over that same time period, if you look at life expectancy at 25 instead of 65, basically at the bottom end of the socioeconomic gradient or the bottom end of the education distribution, there was no improvement in life expectancy, and all of the improvement occurred at the top of the education distribution. So we've heard very little about this. Many of the demographers that I speak to suggest this may well continue, and it ultimately will have effects not only on our healthcare system, but also on those public programs that I started talking about, because Medicare and Social Security, because of this factor, become increasingly less progressive on a lifetime basis as higher income beneficiaries increasingly collect their benefits because they're living longer than the average and lower income beneficiaries. So with that, I will close and open up for questions. Thank you very much for having me.
Thank you.
Questions?
I was opened up generally, and let me just get kicked off by, on comparative effectiveness issue, you could summarize where we are today. What institutions are looking at comparative effectiveness today in terms of government or quasi-government or industry, in terms of whether it's device, procedures, chronic disease treatment?
Yep.
What is the state of the art today?
We're not very far. We're nowhere near where most medical professionals think we should be. So actually, one of the, I don't want to say, I love my job, but one of the frustrations, and it's not even a frustration, but one of the features of it that I've noticed is the Institute of Medicine, which is part of the National Academy of Sciences, is very much now on this theme, recognizing how important it is. And it seems like every day I'm either on the phone planning an Institute of Medicine conference about this topic, or attending one, or speaking at one. So as a reflection of the gap between where the medical profession as embodied in the Institute of Medicine thinks we need to be and where we are, is that level of activity. Now, there is some of this that goes on. Insurance firms do a bit of it, but they don't have the same incentive that we should have as a nation to undertake it, because this information in some sense is a public good. If I find out that the fifth visit isn't really worth it, that has benefits not just to my insurance firm, but to lots of people. Furthermore, Medicare and Medicaid are a big part of the health system, so we should care whether that fifth visit makes any sense or not, and we're doing very little of it as a government. So that brings me to government. There's a little bit of this. I mentioned the FDA does some, or requires some testing that's not really head-to-head, but can sometimes be jerry-rigged into a head-to-head comparison. The NIH does a tiny bit of it, And then there's a tiny agency called AHRQ, or the Agency for Healthcare Research and Quality, within the Department of Health and Human Services, which actually does this kind of thing. But it's really, really small. So there's not very much activity at all. Other countries do more of this. In the UK, for example, they came up with a great acronym, the National Institute for Clinical Excellence, which they go by NICE. So they're nice. They do a lot more of this in the UK, and similarly, there are other countries that do more of it than we do. But there's an active debate going on about how to finance and how to structure and design an expanded effort like this. Some of the key questions there include who should pay for it? Should the federal government pay for it, or should providers pay for it, insurance firms pay for it? And there's often a combination. I think one of the key things is whether it's subject to the annual appropriations process or whether it has a dedicated source of funding so that it's more insulated from political pressure. There's another question about whether it should be located within a government agency or not. And there's debate over the degree of oversight that policymakers would have over it versus its independence and also its credibility with the medical profession. I should immediately say, by the way, you can do all this research. If you don't affect medical practice, it's useless. So you got to do the research and then both communicate it in an effective and credible way, and I think probably ultimately tie financial incentives to it, or you're not going to be affecting medical practice, and just producing more information may be nice, and you can see from some of the variation stuff, like on the aspirin and other things, that sometimes putting information out does matter, and sometimes just putting information out and then measuring whether people are responding to it matters, and we've seen that also with beta blockers and other things. But to really have a kick, you need to be credible with the medical profession and then probably also change financial incentives. So there are those kinds of debates. It's kind of an expanded effort was discussed in some part last year. There are some bills floating around to do more of it now, but I would say we're at an early stage. And the frustration of that is this information and then also the electronic backbone that would allow more of the information to be generated really is key to being able to figure out how to capture that opportunity, because without it, you're kind of flying blind to some degree. And so the typical, which is related, by the way, to the typical shtick about the nation's long-term fiscal problem, which typically is all we need to do to solve the nation's long-term fiscal problem is lock people like what Mr. Fisk used to do in a room. So lock all the senators and members of Congress in a room, don't give them any food, and don't let them out until they solve the problem. And that works for Social Security, where you can pick from a list and there are menus of what the options are, and I've written books on it, lots of people have written books on it. It doesn't really work for healthcare because we have not built out the infrastructure on specifically what would work and what wouldn't, so I don't really know what the people would be talking about when we lock them in the room, because they don't have that table, that menu to choose from. Or another way of putting it is, I have not seen whether, since I took over at CBO or before that, a credible plan that would restore long-term balance to Medicare and Medicaid. In fact, I don't think it exists. And that reflects a lack of information. It reflects the lack of this comparative effectiveness research. We don't know what to do. I think the best that we can be doing at this point is to be putting in place an infrastructure that would lead to some of those answers, but that will take time, and the longer we wait to put the infrastructure in place, the longer we're going to wait for the results.
So you mentioned that it's just not costly and practical to do randomized field experiments on these processes and procedures. And I see how that makes sense for a lot of things. You have to rely on econometrics like the fourth versus fifth follow-up for your research review. But what about like really important procedures that are really expensive, like doing randomized control experiments on like heart disease or heart patients, or just whatever? I mean, identify those top two things in terms of cost and applicability to the population, and do experiments on those.
Well, and I think that's actually, by the way, the other thing on comparative effectiveness research I left out, which is how do you choose what to study and who chooses it? And that's actually an important question. And I think for a lot of the things that have a big impact on spending and about which there is substantial uncertainty, the approach may be different than it is in other settings. All I meant was, we can't rely, I should have said this more precisely, we can't rely, I don't think it will be feasible to rely exclusively on randomized controlled trials. There will have to be a portfolio of different approaches with, a higher, sort of the gold star being applied to the findings from a randomized trial, and then a little more skepticism applied to the non-randomized things. But we're going to have to rely on those for at least a significant part of this effort. Yep.
Seems like almost everything I do about healthcare talks about how messed up the whole fee-for-service model is a way of paying doctors and other providers. And I think you sort of began to mention that under your umbrella about incentives and better care, not more care. Do you think we should get rid of fee-for-service? And if so, what would we move to? What should we move to?
I'm not allowed to use words like should anymore, so let me just say there may well be significant efficiency benefits if we moved away from, my friend Mark McClellan likes to say, instead of fee for service, we need fee for value. Rather than just paying more for procedures, we need to pay more for the better stuff and pay less for the less effective stuff. It's hard for me to see how we can capture this opportunity without changing those financial incentives. I talked a little bit about on the consumer side. By the way, let me pause on the consumer side for a second, and then I'll come back to providers. I think it's plausible, by the way, that workers, one of the striking things about our health system is I think most workers have very little idea how much their take-home pay is being reduced because they have employer-sponsored insurance. And we know, both from theory and empirical evidence, that trade-off actually happens, but I don't think most workers realize it. And a little vignette that I told earlier today on this point, and actually I'll mention names now, I didn't do that before, but Jeff Liebman and Richard Zeckhauser, two leading economists, were writing a paper about behavioral economics. I talked to Jeff Liebman. I said, you should really talk about this thing, the lack of salience of employer-provided insurance premiums. So Jeff, who's a Harvard professor, decided to spend a little time on the Harvard intranet looking up how much Harvard contributed for his health insurance, and spent 30 minutes on the intranet and could not find the correct information. He actually thinks he found incorrect information, and then he realized he's actually not covered by the Harvard plan because he's on his wife's plan. His co-author, well, it gets better. His co-author then said, I forget whether it was co-author or a colleague in law school, said, don't you realize that information is contained on your paper pay stub? And it says Harvard contributes X $1,000. You should know Harvard contributes X $1,000 for your health insurance. And a third Harvard professor at this conference then said, don't you realize that Harvard discontinued paper pay stubs X years ago? And there then ensued a discussion that lasted for about 30 minutes about what information Harvard did or did not provide, and we hadn't even got to what the actual number was, and I don't think anyone knew. And that's just a little vignette into the lack of salience for most workers. A related point. You hear a lot of discussion today about out-of-pocket expenses, co-insurance, deductibles, what have you. That out-of-pocket spending is 15% of total personal health care. A far larger component comes from those employer-sponsored premiums, and you hear almost nothing about that because I think most workers don't realize how much their take-home pay is getting hit. I think that one reason that this very inefficient system is perpetuated is that workers don't realize how much they're paying for it, and therefore don't demand as much efficiency as if they were hit in the face with saying, your take-home pay is being reduced by $7,000 for health insurance, and that may lead to deeper questions about why exactly is UCLA Medical costing twice as much as the Mayo Clinic, and can we do any better than that? So on the consumer side, more salience may matter, and it may also be that more cost-sharing, but changes in cost-sharing can also help, but as I said before, you get not as much traction from that as you might otherwise think because it's only really being applied to the non-catastrophic cases. What about on the provider side? On the provider side, I think the case is much stronger that we get what we provide financial incentives to get. So we provide strong financial incentives for high-end technology, we get a lot of that. We don't provide strong financial incentives for preventative medicine, we don't get a lot of that. And unless we alter the financial incentives, it is asking a lot of medical professionals, most of whom do go into the field with sort of noble purposes, to sacrifice significant personal significantly personally, from a financial perspective, in order to do, quote, the right thing. And there's no reason why one couldn't construct a set of financial incentives that rewarded better care rather than more care. The details of doing that is extraordinarily difficult, and the political economy of doing that is extraordinarily difficult, but I don't really see an alternative unless we want to wind up with perpetuating a very inefficient system.
Just to follow up,
Sure.
do we have to wait until we have more comparative calculated information before we do that in a realistic way, or should we start immediately?
Well, it depends how we do it. I think we should start it, well, I can't say should. You almost got me. It's getting late. Yeah. It shows. I think that there's a lot we can do, but there is a risk. So, for example, a hot new topic now is pay for performance. We're going to pay for performance. Well, if you pay for performance in particular ways, you can actually exacerbate some of these things that I was talking about. It depends exactly what performance you're paying for. And so I don't want to give you a blanket statement that changing financial incentives now in a pay-for-performance way would necessarily lead to a better mixture of outcomes and costs. I do think that there are payment changes that could be made that would start to tilt in the right direction, but it's not sort of an easy thing to do. I'd also note, by the way, that there have been approaches adopted in the past, and actually currently we have a system of paying for physicians called the Sustainable Growth Rate Formula that sort of put a hard cap on total payments. And then in the absence of changing the underlying incentives, and by the way, some people have said, the solution to our healthcare problem, we'll just put a cap on spending. We'll just cap the total. And that's an interesting approach that probably won't work very well, because when you put a hard cap on a total without affecting the underlying drivers of what's causing costs to rise so much, what you usually wind up with is policymakers waiving the cap time after time after time, because you have this building pressure that's unsustainable. Interestingly, with regard to the Sustainable Growth Rate Formula, it's been a mixture of that. The cap has been waived repeatedly. So there was a cap put in basically on total physician payments. Cap's been waived repeatedly, but at the same time, it's been waived sort of partially, and the update factors have not been as large as one would have thought beforehand. So that's an example where basically a hard cap didn't work as formally specified, but it may actually have constrained spending to some degree, at least for some period of time. Yep.
I want to beat the dead horse of the question.
Yeah, let's go for it.
Can you just touch a little bit on, you said that you felt like maybe performance exacerbates the problem. Specifically, which problems do you think would be?
So an example, and I can give you the details. I put up the Mayo Clinic versus the versus medical. There are ways of conducting pay for performance, including based on procedures, where the Mayo Clinic would wind up being financially worse off relative to UCA Medical under pay for performance. That's often a problem in any incentive scheme on whether you measure improvements or levels. And if you're doing improvements, the people who are sort of initially worse have more scope for improvement than the people who are sort of closer to the frontier, and therefore have more limited scope for improvement. And if you do the levels, then the people who start off really not looking so great, depending on the structure of the pay for performance, like if you're only paying the top performers, you may not get much benefit from that because they know that there's no conceivable way that they're going to catch up, and then there's very little incentive for them to do so. Now we're getting lots of questions.
One of your first slides showed sort of massive increase in government spending.
Yep.
Is there a historical comparative from something previous to the healthcare spending over the last 8 years? So was also an expected increase, whether it's in government or societal spending, that was controlled, whether it was spending or Social Security or defense or something else that you can sort of look back and say, well, they expected this to grow out of control and it did, and here's how.
There have been times when we have changed some of the systems, like there were reforms to Social Security in the early 1980s that eliminated a projected imbalance at that time in the Social Security system. But I do not think that there have been previous periods where we've projected a 15% of GDP increase in government programs that we have managed to avert. That is to say, I don't think that there were projections in the 1950s suggesting that around now we'd be spending 40 or 50% of GDP on in federal government spending. Let's go there.
You didn't mention anything about malpractice costs.
Yeah.
That is influencing fees. Do you have any data on that?
Yeah, so I'm going to give you a yes, no, yes answer. So doctors say this is the most important thing in the world.
One of the most.
Yeah, depending on who you speak to, but one of the most. So it's always the fear of medical malpractice means that I'm practicing a lot of defensive medicine that suggests that it has a huge effect on costs. So that's the yes. The no is then there have been some academic studies done on the degree, especially the degree to which the variation in medical malpractice laws across parts of the United States are related to this map. And you tend to find that the states with more stringent medical malpractice laws do not have higher healthcare costs than other states. So that leads the sort of academic literature, as it were, to say it's not a big deal, you doctors are just using this as an excuse. So that's the no part. Now let me come back to the yes part. I suspect, again, I think a lot of this is driven by social norms, and that the more interventionist parts of the country are more interventionist in part because of training and where the doctors wind up, but in part because I'm going to see you 5 times a week or 5 times a month. If the guy down the hall is seeing his patients 5 times a month, it's kind of what's done in this area. And that one of the reasons for that social norm is the fear of medical malpractice. I'm doing what everyone here does for these. This is standard care. And in that case, it's not clear to me if that's an important part of this regional variation. It's not clear to me that small variations in the stringency of state level or local level medical malpractice laws affect the strength of that social norm that much. Which is to say, I may follow a guy down the hallway just as much if the medical malpractice system is a little weaker in my state or a little stronger, that doesn't really matter. In which case, the basis for the academic studies is sort of off. Furthermore, if we did more, so that's now coming back to yes. In other words, I think I may be closer to the AMA than to my academic colleagues on this question. But I'd also say if we did a lot more of this comparative effectiveness research, that may provide, in a sense, a safe harbor. So instead of saying I did what the guy down the hall did, and that or standard practice, I did what the Institute of Medicine suggested was best practice guidelines for a patient with these characteristics, and that's my defense. Could be an important effect.
Both Dr. Princeton, you addressed the comparative factor. NIH used to fund some head-to-heads amongst various pharmaceutical medications.
Yeah.
They've abandoned that for the most part. It was also done in the VA system.
Yep.
They have abandoned it. Some of the best collaborative.
Or they're significantly reduced. Yeah.
Is there a movement at the federal level to have dedicated funding for such studies? Because that would make a difference. Doctors really would give the compound that's most effective. And once we fund comparative studies, what do you envision if you get statistical relevance against placebo, but it accounts clinically for 2%, and it's very expensive? Who decides?
Right.
Antonin Scalia, I'm sure, would say.
Right.
The Democratic Society, the people decide.
Right. So first, I do think that there is interest in expanded comparative effectiveness research, including on pharmaceuticals, with dedicated funding. But coming back to, it's early in the process. Senator Baucus and Senator Conrad, so the chair of the Finance and the Budget Committee in the Senate, have a proposal that they're playing with on the topic. There was a limited effort that was included in the House version of the S-chip legislation that ultimately was was vetoed last year. So you see growing support for it, but it's not yet been implemented. I think, again, and the Institute of Medicine activity suggests, again, there's sort of a lot of talk, and there are a lot of conferences in D.C. on the topic, and like a lot of Hill staffers who are interested in it, but it's not yet, it obviously hasn't been done yet. Who decides? I think likely that whatever comparative effectiveness entity or entities is created or would be created probably would be better off publishing the research, in your case saying here's what it suggests, and not making coverage or financing decisions, and leaving that up to insurance firms and Medicare and Medicaid. And Medicare and Medicaid or the insurance firms would then say, the evidence suggests this thing only works like slightly better. We're not going to pay more for that thing. And if you want to do it, you have to pay more, or differentiated systems like that. Again, coming back to, I think it's not going to be as practical, and I think the backlash against the sort of blunter approach that we saw in managed care during the 1990s is that hard and fast on-off switches are not likely to work that well over time and on a sustainable basis. And graduated payment systems might be more feasible, but they're also a lot more complicated to implement. And so I think the complexity comes at a cost, but it's probably a necessary cost from a political economy perspective. In any case, I don't think you want, I think it's probably unlikely that you want the entity itself conducting the research to then reach the conclusion about what should then be done with it.
I think that funding issue that you mentioned in terms of appropriation versus some sort of continued stream that you implied as well, it is critical. And if you look at the history of ARC, it's a little bit like what you said. Once there, that was the whole purpose of it initially. The administrations changed, politics got involved, it got shrunk down, sort of, from work from people here and others, sort of revived. Still very small. It doesn't have a constituency out there. It does some of the early comparative studies that are there. So the whole is not a movement yet. The Dartmouth data is the best out there, and it's slowly coming. It's not a movement yet, and it needs to be. It takes significant funding, because we're talking about hundreds and hundreds of studies. And I think that's why the randomized controlled clinical studies, that's fine to use a little bit of that, but I think you're going to do that for the 50 different, top 50 most costly procedures out there, or diagnoses, or drugs, huge cost.
And in fact, in a lot of these discussions, for whatever reason, a lot of people are focused on particular funding streams. So, it's often common to say $5 billion a year. And then you say, well, what's this thing going to do? And it doesn't matter what it does, the answer is $5 billion a year. So, significant funding streams that would be necessary. And they're under discussion, but it's kind of hard to reconcile that with the fiscal strains and the pay-as-you-go rules that apply in Washington.
You also didn't mention anything about the increasingly common practice of using paraprofessionals to provide health care rather than physicians. And I was wondering if there was any data as to the quality of the outcome.
Yeah, we don't have a lot yet. So in particular, there are lots of interesting experiments going on. The clinics that are being set up in retail outlets, for example, that are doing various kinds of kind of simpler primary care administration. I should say, from a personal perspective, coming back to the ease and simplicity, one of the great there are lots of great things associated with my job, but one of the great things is having a capital nurse, sort of a nurse in a medical office right downstairs. Because there are lots of things that I, frankly, would not, coming back to my little MRI experience, I would not schlep off to the doctor in the middle of the day and waste time on this and that and the other thing to go do, and like just popping down and saying, like, is this actually a problem or not? Now, obviously, she's giving me advice that may not be as based on as much a broader set of knowledge as my physician is, then again, I wouldn't go see my physician unless it got really serious. And in those cases,
If there were a doctor there instead of a nurse.
if there were a doctor there instead of a nurse, but then again, there's a cost question. So the short answer is there is a lot more activity going on, especially in these retail outlet forms. So going into a clinic at Walmart, for example. But it's very early in the process of evaluating the. We know something about kind of healthcare that's being delivered. We don't know anything about really the longer term or the quality impacts. And I'm very interested in this, so we're kind of actively monitoring, but I can't tell you much yet because I just don't think you know, or we know.
I'll take one more question. Out there.
If there are any.
Okay, Peter, thank you.
Thank you.